Hello, dear friends. First of all, let me express my gratitude to the friends at ATTD for giving us this opportunity. In this abstract, we'll be sharing our experiences on using a virtual COVID IP care in diabetes. And this is a concept to reality. We are in the midst of a terrible second wave of the pandemic in our country. And this time, it is so unfortunate. So I don't have any disclosures for this lecture. So if you look at diabetes or uncontrolled glucose, it increases the chances of transformation of a mild COVID to a moderate COVID, and from moderate to the more severest forms of the disease. And during the current pandemic, we have recognized the overwhelming of hospitals as a very, very big challenge, a global challenge. And when the patients are hospitalized, there are several challenges. And the challenges are with monitoring the glucose, the challenges are with frequent injections of insulin, and there is always the fear of hospitalization. And it is an absolute necessity when patients are monitored and treated at their own houses to recognize the 1% of patients who require a care in the ICU. And that should be an early recognition as well. And this is our strength. The use of telemedicine in diabetes for over 24 years. And this is a center from Kerala, from the south of India. And we have been practicing diabetes telemanagement system from the year 1997 onwards. And we have been successful in generating several evidences based on this practice. And this is a publication involving 1,000 patients, all eligible for a hemoglobin A1C reduction to below 6.5%. We could demonstrate and prove the cost effectiveness of the program. We could have this telemedicine along with structured self-monitoring of blood glucose, avoiding hypoglycemia in achieving a hemoglobin A1C of below 6.5% in majority of these patients, and reaching all the goals of therapy in the patients. And during this pandemic, for consenting patients, we offered a COVID virtual IP care. And this involves 24/7 not only monitoring, but also treatment and advices by a team of 4 doctors, 4 nurses, and the supporting members. A risk assessment will be carried out using an online questionnaire during the first visit. So how is it delivered? The care is coordinated with a dedicated WhatsApp group. So there will be a dedicated WhatsApp group for each patient where the relatives of the patients will be members, and there will be 1 doctor and 1 nurse who will be on duty round the clock, including during the odd hours during the night. And the team will be assessing the vital parameters and the general well-being very, very frequently. And this is an overview, an overall picture of how the care is delivered, is executed via the virtual COVID IP. During the first virtual visit, we will be reviewing the concomitant medications and making necessary modifications. And the patients will be instructed and trained on how they should be posting the vital parameters once in every 3, 4, or 6 hours, which will be customized to the patient's requirements with respect to blood pressure, the blood oxygen levels, the temperature, the glucose values, training on titration, the dosages of insulin. And we ensure that there will be a home monitoring or sampling for the parameters related to COVID-19, and that also based on the requirement very frequently with respect to the CBC, the CRP, the D-dimer, the ferritin, and so on. And for those patients who are the selected patients, a single lead ECG to be transmitted via the Apple Watch, the heart rate, the sleep parameters, remote monitoring with other continuous glucose monitoring devices. So how did we prepare? Last year in 2020, we organized multiple webinars for our patients, 500 to 1,000 patients at a time for almost 20,000 patients. So this is our team involved in the care. And we simultaneously, we created a core team. And we made sure that the team is sufficiently trained for management of COVID-19. Some of the screenshots, these are the videos on how we were delivering the care via the WhatsApp groups, frequent injections of insulin in those patients on corticosteroids, and that too with a faster acting insulin analog, so as to keep the glucose as low as possible without hypoglycemia with more than 90% in target, and keeping the cost simultaneously at the minimum, and offering free treatment to those economically challenged patients. And we ensure that the team is having the expertise to recognize early signals of worsening. Early signals of worsening, so that the patients are put on corticosteroids. The patients may be put on subcutaneous low molecular weight heparin whenever there is an indication. Of course, we were having all these treatments at the patients' their own houses, and the delivery was from the patients and the caregivers from the houses itself. And for those patients not familiar with the use of continuous glucose monitoring, these are some snapshots of Libre. The applicator, along with the loaded sensor, it's delivered at the patient's doorstep, and consequently, the nurses will be there via the WhatsApp video to help the patient on how to use it properly, how to deploy it appropriately, and the same with other remote monitoring gadgets as well. So these are the broad results of the initial 127 patients who were enrolled in the COVID virtual IP. Of course, currently we are having more number of patients, more than 500 patients are being treated currently in the COVID virtual IP. So with the 127 patients, all of them recovered. 11 each of them, we were using a CGM and dexamethasone. 3 of them required low molecular weight heparin. 2 were hospitalized. 1 actually didn't respond to our repeated attempts at counseling, and he was having the fear of death. Of course, this is part of COVID-19, the intense fear of death when somebody is diagnosed with COVID-19. And this is the response to our survey to the patients. Almost all of them responded, and 100% of the patients agreed. They admitted that they were satisfied with the use of COVID virtual IP care. And the virtual advice has been delivered with respect to injections, with respect to the frequent glucose monitoring. And to our question on, did you feel irritated when the nurses were reminding you for monitoring and for having medications? The response was 83% of them admitted that they were not irritated at all. And a minority of them, of course, confessed they were a little bit annoyed when we were trying to remind them. And these are the merits. 99.9% successful program with immense sense of satisfaction, with patients having no fear for mask or for PPE kits, no fear of getting hospitalization. And then with respect to the cost of hospitalization, the cost of getting treated in a virtual IP care for 10 days when compared to hospitalization in India, it is 20 times less. It is 20 times less. Of course, there are demerits. There are demerits of missing the patient, missing the chances of remaining the patients. When the numbers are surging, having the labs at home could be a challenge. Medical legal implications, and this can be properly executed only if the patients are literate, only if the patients are educated. And this particular study, this observance is from the state of Kerala, from India, with 100% literacy. And there are limitations. Most of these patients were used to telemedicine for several years. And the blood glucose is now recommended as the 5th vital sign. And any deviation, high or low, of course, can aggravate the disease. So these are my broad conclusions. Virtual COVID IP need to be studied further, especially at the wake of similar predictions of pandemics in the near future. The virtual COVID IP care need to be more popularized, and this is to prevent, number one, overwhelming of the hospitals and to save the precious lives of the human beings. Thank you very much for the opportunity, and thank you very much for the patient hearing.